Can everybody see now? Well, thank you very much, Tanya and Megan, for offering me this opportunity to share the talk that I presented in Tampere, Finland. And having watched your presentation just now, your conversation about the approaches that resonated with you from a safe communities perspective, I think that this matrix that I'm going to share today is hopefully going to be a practical tool that will help you with the work that you do. I'm not sure that any of you have heard the term multisectoral humility before, and that is because I made it up. So let me start by sharing a definition of it. It's obviously mine. But for me, multisectoral humility is a commitment to an others-focused inquiry and learning process. It requires willingness to accept that multiple sectors and stakeholders influence any situation we hope to change, our willingness to question assumptions, discover our cognitive and emotional blind spots, to ask the right questions of the right people at the right time, and to listen with humility to what we learn from their answers. So the question then is, why bother? Why did I develop this multisectoral humility matrix, and what was the incentive for it? And let me just start by saying that this was not designed as an academic exercise. This was really something that was designed for real-world injury prevention and violence prevention practitioners. I'll tell you a little bit more about the history as we move forward, but I've spent much of my career standing between the academic world and the practice world, and I felt that a lot of the analytical tools that we use in academia really didn't honor the complexity of the communities in which we do business. And so I wanted to just start by laying out the complexity of the work that we do. The first layer of complexity is the etiological complexity. That is, the causes of injury aren't a simple, organism. They're complex, biological, psychosocial, environmental, and so we have to understand the layers of complexity, both to understand the injury and also to look for the opportunities to intervene and promote health as well as safety. There are levels of complexity within our intervention choices, so that we know that maybe we need to change knowledge, but changing knowledge is not enough to sustain behavior. So we may need to improve access to resources or services. We may need to build the capacity for enforcement of policy. There are all sorts of options. We may need to design safety equipment. And then all of us deals with very different socio-political complexity. And that is one of the things that is a problem when we think about just best practice or model programs, because the model program is designed in a context, and we may be in a very different context from the one in which the design happened. We all know about the resource challenges, whether it's working with different people, the technological issues, being able to communicate effectively, the never-ending financial challenges that we face. However, here's a bit of good news, in that I think that one of the things we don't identify often in our work without being prodded with a matrix such as this are all the unidentified opportunities. And when we learn to look into our communities, we find, yes, we find gaps, yes, we find risks, yes, we find deficits. However, we also find resources. We find that there are non-traditional partners potentially willing and able to work with us. And if we look deep enough and early enough, we may find shared interests and cross-cutting benefits. So, for example, working on a walkable community, or the example that was shared earlier, working on access to safe drinking water and protecting water resources, may also have the cross-cutting benefit of reducing drowning risk in the women and children who collect that water. The other reason for developing multisectoral humility is to overcome the illusion of knowledge. Daniel Burston was the Librarian of Congress in the USA, and he said that the greatest obstacle to discovery is not ignorance, it is the illusion of knowledge. In other words, if I think that I know, why would I bother to reach out and ask questions and try and find out what's really going on? And so I think that the reason to learn to use this matrix is to get very comfortable saying, we probably don't yet know what we don't know. It's not an admission of weakness, it's an admission of opportunity. If I don't know what I don't know, I can't learn. Committing to finding out what those gaps are allows me to begin the process of discovering the answers and the potential opportunities in my community. So the history may be interesting to you. This is a multisectoral influences matrix, and the first was about 10 or 12 years ago. I began to realize that the Haddon matrix really does work best for acute injury, and it's much less effective when we try and use it to understand, say, underlying or cross-cutting issues. So We may know what the mechanism of a motor vehicle crash is or a pedestrian injury, but when we try and understand, say, the issues around access to alcohol, for example, those are much more complex and nuanced than really suits the Haddon matrix. And then when I was teaching students in the United States Indian Health Services Injury Epidemiology Fellowship Program, several of them shared their challenges in addressing injuries when multiple sectors or multiple stakeholders were involved. So for example, the one that really got me on the path to developing this matrix was a student who was trying to address pedestrian injury in an area of road in Arizona, I believe it was, and part of the road was owned by the nation, the Indian nation itself. Part of it was owned by the state, and part of it was federal. It was protected, and so it was very complicated to get data because different people owned different pieces of the data, and different people had different mandates for intervention in certain areas. So I developed it initially with the Indian Health Service students, and then I've refined it over 10 or 11 years with students in graduate injury and violence prevention courses at Johns Hopkins School of Public Health, at our Summer Institute, our Injury Prevention Institute. I use it in a problem solving in public health course. I've used it for scenario development in a master's level nursing leadership course. We've used it in a public health leadership certificate program that was not exclusive to injury, and we've used it in various injury and violence prevention workshops throughout the country and in fact now internationally. So let me introduce you to the components. It'll feel a little overwhelming for a minute or two, and then I'm going to walk you step by step through how we use it. Like the Haddon matrix, it has three phases: a historical phase, a current or status quo phase, and then a future phase. We have to develop overarching issue statements and phase-specific statements. So what is the issue that we faced historically, what is it that we face currently, and what is it that we will face moving it forward. We recognize multiple levels of social influence, and these can either be sectors, as in educators or emergency responders, or it could be actually down to the level of certain individual stakeholders who hold power and influence. Sometimes we call these the gatekeeper stakeholders. It considers physical and built environmental factors, and it also considers product or policy factors. And each of these is customizable to your specific community or context. Don't get panicked by looking at the whole big picture here, but realize that we start by asking a series of questions. And I'm not going to say where we start. Let me just read you the questions for each of the phases. So as we begin to think about an issue in the current time, we're wanting to say, what are the factors that are influencing the status quo for this sector or stakeholders? So we know from our professional perspective what we think the factors are that influence this. But when we say that, we think police feels this way or engineering feels this way, another member of the community feels this way, we're actually just guessing and assuming. And so therefore, this is a process of disciplining ourselves to really identify the questions that we need to ask of our partners. Don't assume ever that there's consensus in a community about the need to change. And in addition to thinking about the people who are actively opposed to us, sometimes we need to think about who are the people who just benefit from preserving the status quo and do nothing moving forward or moving backwards. The issue, though, is that we can't assume there's no history. When we try to change something in the present, we must discipline ourselves to say, how did we get to this current situation? And not just how did we get here as a whole community, but how did each of these stakeholder groups get to this current situation or this current position that they hold? What is the history of the problem? Is there a history of previous attempts? Because one of the examples I learned of was my colleagues in the Indian Health Service were really struggling in one community to have intimate partner violence screening in the hospital accepted. And this was puzzling them because other hospitals in this same nation were accepting it. So it wasn't specific to this particular American Indian group, because there had been broad spread acceptance of the screening up to this point. And what I asked my student was, I asked her to go back and say, what happened here? Because given the resistance, my sense was there was something that had happened here. And in fact, what had happened was that they had been the first hospital in this nation to adopt intimate partner violence screening. but the physical environment was not suited to private screening, and so somebody had overheard a young woman talking about her husband's treatment of her, and she was almost beaten to death subsequent to her discharge. And so the community had said, this is too risky, we can't possibly go forward with this. And so their resistance was rooted in a negative history with the screening. Ultimately, we were able to move it forward through identifying a key stakeholder. But then, as we think about what it is that we have to do and how we move it forward, we need to be thinking proactively about what are the factors that will influence the adoption or sustainability of our intervention or our policy. And what are the things that we could learn about and do now in this current phase that would help us anticipate and plan for the opposing forces? Now, those of you who've done policy work understand this very, very well. So how do we go about completing the matrix? We start by identifying the issue that we're analyzing. So it's not going to be as broad as the fact that, say, we have distracted driving. It could be, but we may even know very specifically that there are certain times or situations in which people are distracted. There are certain age groups in which they're distracted. It could be an issue with access to alcohol that people have in our community. And so we state the general issue that we're analyzing. We're not calling it a problem here because we don't actually know what the real problems are yet. This is the issue that we're addressing. So then in the current phase, we're going to say, well, what is the issue? So we say that currently we know, for example, that youth have very easy access to alcohol in our community, despite the fact that we have some restrictions on young children, young teenagers having access to alcohol. Well, historically, was that the case? Do they have easier access now, or has this been a long-standing process of having access? And then similarly, as we move forward, obviously our goal is not to ban it completely, but we need to think about what would a reasonable situation relative to alcohol, access to alcohol, look like. Before we can begin to ask any questions, though, we need to say, who are the players? So we first state the issue because the players in the story, the sectors or the stakeholders, are relative to this issue. So if we're talking about youth access to alcohol, say, in my community, then we would say, well, who are the people who influence, who are the stakeholders here? So obviously the youth themselves, but maybe the people who distribute alcohol, people who license alcohol outlets, maybe the colleges or schools, people who enforce alcohol. So we really need to think about who are the people who are going to be players. Imagine you're actually setting up to develop a movie or a TV show about this issue in your community. Who are the people you put in the cast list who would show up as you told this story? Now, we have 5 here simply for convenience, but very often in communities we'll be looking at 16 or 20 stakeholders that we identify in a community. And so once again, once we've identified the stakeholders, for each of them, for each of the people, we'll now have labeled, given a name to level 1, level 2, level 3. So it could be the students, it could be the alcohol board, it could be the police. We would say, well, what are the factors that are influencing the current status quo about this organization's response to youth access to alcohol? Which of them are modifiable? And then we do it for the history, and we do it for the future. You may say, well, how could I possibly do that? I don't know. I would be guessing if I were to ask and answer those questions. And this is exactly my point. And this is why I think Safe Communities is just such a perfect group for pioneering the use of this work in your region. Because I recommend collaborative completion of the multi-sectoral influences matrix. What I do is I try to bring stakeholders together, either in person or virtually with a conference call or a Skype call, and we will say, well, we're facing a challenge, say, with youth having access to alcohol. And collaborative completion of the matrix allows us to have what I call inquiry-focused conversations. So as a group, we sit and say, well, who do we think the people are who are involved? And then we could actually ask of, say, police or emergency responders, school leaders, and so on, what they think about these issues, what they think could be done about them, what the challenges are they think exist within their organizational setting. But it allows people to not be challenged as the adversary. It allows people to contribute different perspectives and contribute insights, and it allows us to challenge the assumptions we may have about each other, about each other's perspectives, about each other's willingness to do the work, or frankly about each other's availability to do it. And so often historically, when we in injury and violence prevention design interventions, we've done all this thinking. We make a decision about what needs to be done, and then we go and ask our partners to help us. But that's kind of, frankly, rude, because we're asking them to do something that is ours. When we are other-focused and we welcome them into this collaborative completion of the process and the collaborative identification of potential intervention points, then this response truly becomes ours or our communities, and it's completely consistent with the values of the Safe Communities approach to injury and violence prevention. So then why do we fill it in using questions? Well, for many years we filled it in just with, we think this is what they know, we think this is what we need to find out, but we found that people had a hard time stepping into this place of humility where they were genuinely trying to learn what other people thought about this issue or what other people could do. And one of my students about 3 years ago said, if we were actually to fill in the matrix with questions, the questions that I have, say for law enforcement, or questions I have for the traffic engineers, it would lower the likelihood that I would be making assumptions-based statements like law enforcement believes X, the traffic engineers won't help do that, they don't understand our world, it's always been this way. And whenever we make a statement like that, this is actually, it's not a fact. And so one of the great goals I have with teaching people to use this matrix is to move us from a place of assumption-based decision-making to a place of inquiry and then information-informed decision-making. And then the rationale for including assets-focused questions, people, this is the aspect of the matrix with which people struggle the most. Because people are very comfortable, myself included, in identifying risks and deficits and barriers and things that people can't do or won't do. And over the years, I've noticed that most of the questions that get placed in the matrix start out by being the negative ones. What's missing, what can't we do, what hasn't happened before, and so on. The greatest opportunity for us is to discipline ourselves to also include assets-focused questions. Now, this is difficult because our brain is designed to have us notice risk and deficit. So in order to be able to very skillfully look at the assets-focused question, it's something we need to practice. So, for example, questions such as, is it possible that in this community, given these same resources and these same belief systems and these same policies, we have kids who are not accessing alcohol, are not at risk of alcohol-related injuries? What is it about them, given that they're in the same setting? We will also find that within organizations, we always have positive outliers. We always have the greater collaborators. There are things being invested in health-related work in communities. And it may not be immediately apparent that this is relevant to us. We may not see it as a public health skill or a public health asset. But the fact is that, for example, when we have access to an asset such as the wisdom of our elders, the access to the history of this situation in our community, this is a great gift to us that we should honor and leverage. And so we need to recognize that typically the negative, when we don't look for assets, we tend to really then elevate our attempt at looking at deficits and barrier-focused interventions, so reducing risk, preventing illness, preventing injury. When we increase our focus on assets and opportunities, then we're going to switch much more to a wellness paradigm where we're looking at safety promotion and wellness promotion in our communities. How have we used this? We've used it in many, many situations. So I use it personally to teach critical thinking, because critical thinking is thinking that we question, or we question assumptions and go into the thinking expecting that we may be wrong. And that's okay. It's not okay to remain wrong, but it's important to believe that it's important to recognize when we're wrong. It definitely supports collaborative problem analysis and solution finding, and we've used it in projects in many phases. So early on in a pre-assessment or pre-formative phase of a program where we really don't know yet what's going on, we haven't made any decisions about we don't even really know what the exact problem is or what the exact resources are. So very much in an assessment phase, figuring out who to ask, what the questions to ask, who we should be asking, what sort of data we should be collecting, who would be key stakeholders, and so on. So I've had many students work on this area. I've also had people use it to think through the formative or developmental phase of the new intervention, where they actually do know what the issues are, but they're now having to come up with some intervention decision-making or some policy, some strategic decision-making. I've had several students use it to think through the replication of an existing evidence-based program or policy. So this is translation. So, for example, they know it's worked in community A, and now they want to move it to community X, and community X looks very different from community A. And so what they will do is they'll look at who do we know was involved in the initial program in community A, and who are the comparable stakeholders in our community in community X, and do we have additional people we need to consider. We've used it for quality improvement, both ongoing. So I had a student who was involved in sexually transmitted infection risk reduction, and she realized that they did not have a robust way of actually monitoring or evaluating the program, and so she used it to look for the opportunities with stakeholders and partners to do quality improvement. I had a student work internationally to review a program that had worked pretty well, but they had continued to have some implementation challenges. It was during the response to the Haiti disaster. And what she found doing the retrospective analysis for her agency was that there were 2 or 3 key stakeholders who had been left out of the implementation team. And so she was able to redesign the implementation team moving forward. And then we've also used it for evaluability assessment, which is to say, you know, what pieces of this are evaluable, what are the key steps that need to be evaluated, and also thinking about logic modeling in terms of what are the resources coming in, what are the activities that need to be done. So there's a wide range of applications of this model if we choose to apply it. But at its heart, it's really not about boxes and checking boxes and filling up boxes. It's really about creating space for discovery. Because when I think I know, or when I don't have time to commit to finding out what I don't know, there is no space for me to discover what exists in my community and what incredible resources and wisdom exist in my community and the people of my community. And so therefore, I hope that you will give it a try, don't overthink it, brainstorm it, enjoy it, and recognize that humility is perhaps the greatest opportunity that we don't exploit nearly often enough. So thank you for spending some time with me, and I would be delighted to answer any questions either now or by email.
Thanks, Carolyn. That was great. And I think, as you said, you gave great examples of the application of the matrix and how it can be used with our programs in safe communities. So if anyone has a question that they would like to ask now, let me put your hand up, please, or ask the question in the question box. If not, we will assume that you will all contact Carolyn directly. I can't see the hands flashing up at the moment.
Yeah, we can wait. Think about a question.
Sure. We can give a wait. Does anyone have anything that they would like to ask of Carolyn? Any other examples that she may have? I think she covered many of them. But is there anything else that people would like to know about using the matrix, accessing resources? If Carolyn can provide any training that we've spoken about maybe for 2017, if anyone's got anything they would like to ask. Everyone's being very shy today by the look of it.
Well, maybe I can tell you a real story about something that happened when we used this matrix. We were applying for a grant. It was a wellness program where we had to have, it was really about safe and healthy communities, but it was more from the healthy community perspective. And there were pieces of this grant application that were really challenging to us because they required us to have access to data about children's BMI and all sorts of things. And when we contacted the school said, oh no, we can't give you that. The school health people said we can't give you that. The health department said we don't have that. But what we did was we brought together a group of people to do this collaborative thinking about this issue and what it would take to both deliver these programs but also meet the requirements, the funding agency's requirements. And while we were having, we had brought the nurses and the health people together, but we'd also brought the phys ed people. And the phys ed people said, you know, really, we can give you the data because we're not allowed to collect BMI. The health suite's not allowed to do it because people are sensitive about a weight, you know, here. But they say, but we have mandatory phys ed, and at the beginning of each semester, we take the children's height, weight, we look at their cardiovascular fitness, we look at their flexibility, we look at their strength, and at the end of the semester, we gather those data again to see how well they've done through the semester. They're de-identified, but we can show you changes in cardiovascular fitness, flexibility, strength, and BMI. And so the fact that we had the people at the table meant that we didn't have to invest in that part of the program. There was also another part of the program that required us to invest resources to send somebody to Atlanta to be trained to administer the youth risk behavioral I forget the exact analogy acronym, but it's basically the behavioral risk factor surveillance system for youth. And the people from the school system said, oh, don't worry about that. We sent somebody for that training last year, so we have someone certified in that for the next 5 years, so that's another place you don't need to invest. And then finally, Rec and Parks turned around and said, well, we've already banned sodas, and we've already got rid of this, and we only have water available. So we realized that there were all sorts of things going on that had already moved us along the pathway to our goal, but also there were several things that were required in terms of the grant that we just plain didn't have to do because they've been done already. So huge time and resource saver for us, and that was purely a function of doing this collaborative planning together.
Thanks, Carolyn. That's a really good example, particularly for Australian communities who have difficulty accessing lots of the data. So I think that's a great example of looking at different ways of accessing those things. Still no hands up, so I will thank you on behalf of all the participants, Carolyn, for your time, particularly in your evening, and hopefully you will get an email from anyone who has any questions that they would like to ask you. So just a reminder that the webinar has been recorded. It will be available early next week, and please feel free to share this with your colleagues. So we're encouraging you to complete the survey at the end of the session or in the follow-up email as we're now planning for 2017 series. So please let us know the topics that you'll find most useful. And finally, thank you to all of our participants for being part of this webinar today. Enjoy the rest of your day. Thank you.
Thank you.